So, what did we do? We did a lot of things, and as you can see, we advanced on a large number of fronts with our integrated care strategy. Now, I'm not going to talk about all of these today. I'm just going to talk about the ones that are highlighted in red there, that are specific acute demand management programs. But one of the key points is, if you read any literature on acute demand management or integrated care, all of the advice is advance on many fronts at once. If you're going to change the culture of a health system, you've got to do a lot all at the same time, because otherwise these will be marginal programs that people will look at with a great deal of interest and think it's not about them. So you've got to advance on multiple fronts at once and look for some synergy between all of these kinds of initiatives. So all of our freeboard of money inside the Counties Manakau system went into these initiatives. It's not to say the hospital, Middlemore Hospital, and the infrastructure that sat around it, it's not to say that was standing still. It took a lot of initiatives through this same period, but its funding stood still. We essentially froze funding for the provider arm of Counties Manakau DHB and said, we know your demand is going up, we know your costs are going up, but for the greater good, your funding is going to be frozen for at least the next 3 years. There were some interesting responses to that, but most importantly, people realised why. There was a great deal of energy went into telling the burning platform story, and this was a point Frank made this morning. People need to understand why we're doing what we're doing. It is probably the most important aspect of any integrated care strategy, is around building a sense of the burning platform and building a sense of what contribution individuals and organisations can make to the solution. This is about people's jobs, it's about people's careers, it's about people's research interests, and so people need to be willing to sacrifice some things for the greater good, and that is a difficult ask. So what we were trying to do in this work was essentially to shift the balance from acute episodic care to planned and structured care, particularly around chronic disease. We were also trying to shift it from being a doctor and specialist driven system into one that was around multidisciplinary teams and planned and structured care. And we had this phrase which became a bit of a mantra, which I'm sure you'll recognise from other settings: making the right thing the easiest thing to do. Historically, the easiest thing to do was for the doctor to ring up Middlemore Emergency Department and say, I'm sending a patient in. We had to replace that way of working. So I'm going to talk about 3 particular initiatives that we took and later on look at what some of the impacts of these are and then how they've been built on in later years. So the 3 programs I'm going to talk about are the Chronic Care Management Program, Primary Options for Acute Care, or POAC, and the Very High Intensive User Program, VHIU. So Chronic Care Management Program essentially was structured care for people with high clinical needs. It was at the high end of clinical needs, so there were very tight clinical entry criteria to these programs. The programs were developed jointly by primary care and by specialists, and there was shared clinical governance across this program, and implementation of it was led by the DHB's Director of Primary Care, who was a GP working for the District Health Board. So what was the program? It was heavily based on the Wagner model, which I'm sure a number of you will be aware of, and used the Kaiser approach to how the services were delivered. We borrowed liberally from experience elsewhere, which I would encourage you to do likewise. There was a focus on 5 disease modules: diabetes, CVD, CHF, COPD, and the 5th one was depression. What the program did was target high needs patients who met clinical entry criteria. By this stage, of course, all patients were enrolled with a general practice of their choice. So we knew where patients were enrolled, who the accountable clinician and general practice team was. When a patient met these entry criteria, the general practice was fully funded for 4 GP visits per patient per year and 6 hours of nursing time per patient per year. There was IT wrapped around this with structured notes that was embedded in the practice's existing computer software. There was a defined model of care for the patient. There were clinical pathways, and there was electronic decision support to help make the right thing the easiest thing to do. There was strong support from a specialist clinical leader in each of these programs. There was monitoring, a set of KPIs was monitored regularly. There was support go back into the practices that weren't doing well, that weren't achieving the results. And most importantly, there were patient-held care plans around what the goals of treatment were and what to do when things weren't going so well. And also in the hospital system, there was a flag in the emergency department when a patient turned up who was enrolled in one of these programs. ED was aware of that and could see the patient notes. So that's the first of the programs I'll talk about. By 2009, so 7 years after we started, over 16,000 patients had been enrolled in this program, which we thought was pretty good going. Really importantly, I've got a profile there of the ethnicity of the people who were enrolled in the program. So you can see that Pacific and Maori are hugely overrepresented there, which is what we wanted. This showed we were reaching the people with the highest needs and the people with the outcome inequalities. And really importantly, because access to medicines had been such a problem historically for Maori and Pacific populations, what our analysis showed is that they were just as likely to be taking key medications such as statins when they were enrolled in this program as people of European or other heritage. The second program I'll just touch on is called Primary Options for Acute Care. So this was intended, as I said, the GP just about to, got a patient in front of him or her, just about to pick up the phone and do a referral to the hospital. What this program was intended was to give them some other options, things they could commission themselves that were an alternative to sending somebody to the hospital. Because experience showed once they turned up at ED, their chance of being admitted to hospital were really high. Because these are sick people. What was done was to create a menu of community-based services that could be delivered to this patient in a timely manner, and case management or care coordination could be wrapped around that patient to make it really easy for the GP to hand over the patient to somebody who was going to make sure that the patient got that mix of care that the GP had ordered. So what were some of these services, the menu of services? Intravenous treatment for cellulitis was the single most common treatment. So this was done in the practice. So think of this as, so IV, the practice got paid for doing this for patients. Speedy access to imaging was really popular, but they didn't have to go to the hospital to get the imaging. The imaging was paid for in the private sector. The practice could be paid for an extended consult. So this was an environment in which there were still quite powerful fee-for-service drivers for general practice. Time was money. This was a way of paying them for the extra time in dealing with a particular patient issue. The practice was paid for assessing and observing the patient for a while to see what happened instead of that being done inside ED. Consumables were paid for. The GP could order an overnight stay in a residential care facility and the program would pay for that. So, in other words, access to 24-hour nursing care. Home care, so a hospital in the home kind of service could be commissioned out of this, or maybe there was an issue around patient transport to something that could be paid for, or the GP could be funded for a home visit. There was a whole suite of options that were put in front of the GP, and a PHO managed the overall infrastructure for this program, so the care coordination, managed marketing of it to general practice, and also managed a budget for this. Each GP had a notional budget of $300 that they could spend on that particular patient at that time. Interestingly, actual cost ended up averaging $186. So a lot less was spent than we thought might be spent. And there was, as you might imagine, there was great return on investment with this program. As soon as somebody hits ED, their chance of getting admitted are really high and the cash register starts running. So by running low-cost interventions inside a primary care setting, it had an immediate impact. This program wasn't invented in Counties Manakau. We picked it up from Pegasus in Canterbury DHB, and it's now operating across 8 DHBs, including all 3 Auckland DHBs. So if there's one thing I would encourage you to have a look at, it's this. You know, you may be doing variants of it now, but it's easy to implement. You can steal every good idea under the sun, and GPs love it. The third example I'll give is very high intensive users. Now, so think of this as the frequent flyers. This is not necessarily frequent flyers in the emergency department, it's frequent flyers with hospital admissions. And as we all know, a small number of patients consume a huge amount of the resource. At the time we introduced the chronic care management program, we'd played around with this and showed in the first year a fantastic return on investment, a reduction of 5.7 days per patient per year. But anybody who's had a look at the literature around this realises that there are some flaws in this. It's the stats people call it reversion to mean. So just because you've been a high user last year doesn't mean you'll be a high user next year. And so one needs to be really careful with this kind of initiative that you don't put a whole lot of resource into people who weren't going to be high users anyway. So you need to take a long view of this, and I'll pick up on some of those issues in a moment. But essentially this was a program that was aimed at people with a long-term condition and greater than 4 hospital attendances in the previous 12 months. There was an integrated team wrapped around this, and really importantly, this was personally led by Professor Harry Ray, who took it upon himself and has done for 20 years to model the way around integrated care. He personally led the clinical team that looked after these patients out in community settings. He was a respiratory physician by background. He became Professor of Integrated Care, which was a role that he shared with the local GP. And he still to this day is running this program, seeing these patients out in community settings. with his clinical team. So that team is 2 physicians and some highly skilled nurses, and their job is to do an initial assessment of these people, put a care plan in place and manage them back to their home general practice. They've got a budget at their disposal. They use a risk assessment tool to look at where there are social drivers for admissions, not just clinical. They make big use of case conferencing, including with the general practice. The reason they do that is not because they think they get great returns directly from case conferences, but it's because they get everybody in the room. This doesn't happen otherwise. Everybody who's involved in care for these complex patients, most of them don't even know each other. So this is a way of breaking down some of these barriers that exist between health professionals who are even working in the same community. Individual care plans are a really important aspect of that. So, by 2009 then, where had this got to? So after 7 years, there was a 74% increase in dispensing of pharmaceuticals. Now, this was a pretty frightening thing because we paid for pharmaceuticals as part of our global budget, but this really closed in on national average access to pharmaceuticals, which we took as real marker of improved access to primary care. There was 95% population enrolment and capitation payment, so the uptake of this inside our community had been fantastic. And our high needs populations were making a 15% greater use of general practice than they had been at the start of this process. So engagement with primary care was fantastically improved. And as I mentioned, enrolments in the chronic care management program had climbed to a very high level. Most importantly, for the sake of this presentation, emergency department growth had flattened and was that at demographic growth. So as I said, our population was going up by about 3% per year, and we'd managed to flatten emergency department, total emergency department use, which is the blue line here, that had flattened right out and was really just at demographic growth stage. And what had been 11% growth per annum in hospital admissions was reduced to 3 to 4% per year, which was around that was expected because of population growth and ageing. So 7 years, that's what can be done.